All right, good afternoon, everybody. Welcome back. Sorry to cut the break short. We're going to keep going here with our session number 2 on peripheral arterial disease. I'm joined here with Dr. Liang and Dr. Ali Cusson, who will be moderating the session. So please take a seat and we'll get going. To be fair to all the papers in the program, it's really important that we enforce the time limits strictly on presenting authors and discussants, because we have a very full program. We want to give everybody a chance to speak and have an opportunity to discuss. So full oral abstracts are 12 minutes, video abstracts are 8, and mini abstracts are 5. So furthermore, just for those of you that are following the order of the presentations in the app is incorrect. The correct order is that which is online. However, the time limits are still the same. So for all those that are presenting, just stick around because it might be a little bit different than what you see in the app. I'll go ahead on behalf of my co-moderators here to present the first talk, Plasma Fibrinogen Change as a Predictor of Bleeding During Catheter-Directed Thrombolysis, Dr. Dory and colleagues from Washington, D.C. Thank you. Welcome.
Great, thank you. Good afternoon, everyone, and thank you to the SCVS for allowing me to speak about our work here. I have no disclosures. Okay. So catheter-directed thrombolysis is now an accepted minimally invasive alternative for open thrombectomy for people who present with acute vascular occlusions. As we all know, bleeding is one of the most feared complications during this procedure. Of course, we follow patients' clinical exams closely to try and predict this, and also some markers, including plasma fibrinogen. And this is really born out of the initial data from the STYLE trial that was published in the early 90s. And thereafter, a sort of a threshold of 150 kind of emerged as the de facto standard. But looking at the literature, and in fact in conversations on the break, it turns out that there's some variation in how this is applied in clinical practice. Some people monitor it, some people don't. Some people use it to change their infusions, and the sort of perception of how useful it is in terms of predicting bleeding is sort of varied amongst interventionalists. So the question really arises is there an absolute value at which bleeding sort of has an inflection point and we should use that to direct infusion? There has been some additional research that looks at whether the duration of lysis or the total dose of TPA is predictive of bleeding. And in fact, there's some interesting data from the stroke literature that shows that it may actually be a rate of change or the change in fibrinogen that may predict bleeding, which of course kind of aligns with the biological mechanisms you might think about. Nonetheless, in 2017, there was a systematic review that found that this sort of association between bleeding risk and plasma fibrinogen is not really proven at this point based on the extant data. So what we really wanted to do in this study was kind of look at that relationship a little bit more closely and see if there is something about plasma fibrinogen that helps us predict bleeding in catheter-directed lysis. Primarily, we wanted to evaluate that existing static threshold of 150, but also look at the relationship between the fibrinogen change during lysis and bleeding risk. And we also looked at a couple other factors, including duration and dose of lytic, as that had been looked at previously. So we did a multi-center retrospective review across 4 hospitals in Maryland for all patients undergoing catheter-directed lysis in a 5-year period. They were done using sort of standard CDT techniques, and mechanical aspiration was used at the discretion of the attending surgeon. So using this methodology, we had 438 patients in our data set who underwent lysis during the study period. 69 of them had major bleeding. And looking here at the baseline characteristics, the real difference was about the age, with the patients who experienced major bleeding being somewhat older. All right. So in addition to looking at the baseline characteristics, we also looked at the nature of the occlusion and the conduct of the lysis itself to see if there was any other correlates there of major bleeding. And I know there's a lot of, let's see, this works perfect. There's a lot of data here on the screen, but basically we have our data partitioned as either no major bleed or major bleed, and looked at a comparison of TPA bolus dose, total duration, whether or not they received systemic heparin or mechanical aspiration, and found that there were no differences whether those patients experienced bleeding or no major bleeding. What was different is where the type of occlusion was. So Patients who had native vessel thrombosis had a slightly lower incidence of major bleeding, whereas those who had in-stent thrombosis had a higher rate of major bleeding. So looking at the fibrinogen data a little bit more closely, there's a number of things here that I'll point out. The first is that at no point during lysis did they have a difference in their fibrinogen if you're comparing patients who either had major bleeding or did not have major bleeding. That was true in their initial fibrinogen, their final fibrinogen, or their nadir fibrinogen throughout the conduct of lysis. Also looking at patients who did drop below that static threshold of 150 milligrams per deciliter, we did not find a consistent association with major bleeding in that group. However, what we did find is that a change from baseline was an associate of major bleeding. That was true whether it was an absolute decrease or a % decrease from baseline. That was in the univariate analysis. When we controlled for the age of the patients and whether or not they had in-stent thrombosis versus native vessel, because that was significant previously, only the % change from baseline remained significant. So we wanted to take that finding a little bit further and see if we could have any predictive utility of the change from baseline. And using ROC analysis, we tried to find what % change from baseline or what absolute value from change from baseline would be predictive of major bleeding. And as it turns out, about 47% decrease or an absolute decrease of 146 milligrams per deciliter was the most associated with major bleeding. But the corollary to this was that if neither of these were true for a patient, the negative predictive value for major bleeding was about 90%. And that actually remained true if we simplified the numbers to 50% or 150, just for ease of use. So in conclusion, when comparing patients who had major bleeding versus not major bleeding during lysis, looking at fibrinogen, there was no consistent association between a nadir PFL of 150. The change in fibrinogen from baseline was a significant predictor of major bleeding in our patient set, and that corollary that if they did not have a decrease of 50% from their baseline fibrinogen or by 150 milligrams per deciliter, the negative predictive value for that group was 90%. And hopefully these findings may sort of add to the clinical gestalt when we're having a patient undergo catheter-directed lysis. That's all. Thank you.
Thank you very much. The paper is open for discussion.
Hi, great paper. Thanks for sharing that with us. We have like a sense that when the fibrinogen falls that we're having successful lysis. I'm wondering if you have any of that sort of information from your data.
I do, but you're going to have to wait for the poster presentation on Tuesday. So the spoiler is that no, there's not a significant association. So even if the fibrinogen remains stable during lysis, that is not a predictor of failure of lysis, despite what's in the cardiac literature about failure of lysis.
How do you describe major bleeding? And when you obtain your baseline value for fibrinogen from the baseline, is that after initiation of thrombolysis? Because usually these patients will come in on on heparin drip or something along those lines. So when did you consider the baseline dose, just for those out there?
Great question. Yeah, so the major bleeding was either intracerebral hemorrhage, hemorrhage requiring transfusion, or for some other reason we had to stop lysis because of a bleeding complication. It did not include minor complications like hematuria that resolved, for example. In terms of the baseline, so of course in the ER they were not drawing fibrinogen, but when the patient went to the lab and then went to the ICU after, we did collect fibrinogen level immediately upon arrival to the ICU, and that timing from initial initiation of lysis to the first fibrinogen was not different among the three groups. It's on one of the earlier slides, but it was about 1.3 hours after initiation that initial fibrinogen was drawn.
Thank you very much. Okay, thank you very much.
Thank you.
Our next presentation is by Dr. Sanders and colleagues out of UCSF in San Francisco, and it'll be entitled "The Femoral Popliteal Atherectomy in the OBL is Not Cost Effective for Medicare."
Right. Thank you for the opportunity to present. I'm a general surgery resident at UCSF. So we sought to evaluate the cost effectiveness of atherectomy and hypothesized that atherectomy would be more expensive and less effective than plain balloon angioplasty in the OBL setting. We used a decision tree model to quantify the cost effectiveness of both treatment strategies. We modeled the scenario of a patient with intermittent claudication attributed to a femoropopliteal lesion that is treated in the OBL. The events modeled include the probability of bailout stenting, reintervention, amputation, and 1-year survival. Each terminal branch of the tree is assigned a cost and a utility value. Probabilities are derived from randomized controlled trials that enrolled up to Rutherford Class 5. Only 3 RCTs met inclusion criteria for atherectomy, and it's worth noting that the probabilities generated from these 3 trials are far more favorable for atherectomy than what has been demonstrated in subsequent high-quality observational studies. Costs are based on the Medicare non-facility reimbursement rate, and utilities are informed by the best available evidence. The strategy of atherectomy was associated with an incremental cost of over $5,000 and an incremental effectiveness of 0.012. This amounts to an incremental cost effectiveness ratio, or ICER, of nearly $500,000 per QALY. In order to meet a willingness to pay threshold of $150,000 per QALY, the reimbursement for each of the atherectomy CPT codes would need to be reduced by 42%. One-way sensitivity analysis for each of the variables included in the model revealed that our estimates were most sensitive to the rates of reintervention for both treatment arms. Regardless of how we varied each variable, the ICER failed to reach the willingness to pay threshold denoted by the thick black line. We then performed a multi-way probabilistic sensitivity analysis and found that the current reimbursement rate for atherectomy was cost-effective in only 0.5% of simulations at a willingness to pay threshold of $150,000. Even at a threshold of $1 million per QALY, the strategy of PBA, or plain balloon angioplasty, was still more likely to be cost-effective. So the greatest limitation of our study is the paucity of high-quality data for atherectomy. Other limitations include that our time horizon was limited to 12 months, which may not be long enough to capture all of the relevant clinical events, and that our analysis of each treatment strategy was examined as definitive therapy. In summary, we found that even in the best case scenario, atherectomy may provide a marginal benefit over plain balloon angioplasty. However, it does so at a cost that is unlikely to meet even the most generous willingness to pay thresholds. In order to be cost-effective, the reimbursement for atherectomy would need to be reduced substantially. So, thank you for your attention, and I'd be happy to answer any questions.
This paper is now open for discussion.
William Schutz from Plano, Texas. I'd like to congratulate the authors on looking at an economic analysis for how we take care of our patients and whether we're good stewards to the healthcare system in regards of how their money is spent. One question, and perhaps this can be considered as a criticism, is it fair to compare atherectomy just to plain old balloon angioplasty? And why did the authors select this as their kind of comparison? For instance, usually when we use atherectomy in the outpatient setting, we're using this as an instrument to reduce the use of stenting. Would have been a more fair comparison to help us make good financial decisions to compare atherectomy versus balloon angioplasty and stenting. Thank you.
Thank you. It's a good question. So because of the limitations of the data, it was difficult to compare combination therapies. I will say that bailout stenting, or stenting done at the same time of the procedure, was actually included in the analysis in the decision tree. And so the rate of stenting and the associated cost with stenting is actually accounted for in these results.
Dr. Islami?
Very nice presentation, and it's an important topic. I'm just curious about how you actually calculated the cost, and especially at the OBLs and things like that, because obviously costs and charges are a bit different. So if you can comment on that.
Absolutely. So the costs are determined by the Medicare non-adjusted, non-facility reimbursement rate. And so this is essentially a national average of what OBLs are reimbursed for charging for that CPT code. The CPT codes are based on plain balloon angioplasty plus or minus stent and atherectomy plus or minus stent.
Thank you very much.
Okay, thanks.
Our next paper is entitled 10-Year Experience with Endologic AFX Endograft for the Treatment of Aortoiliac Occlusive Disease. This will be presented by Dr. Knowles from UNC Rex Hospital in Raleigh, North Carolina.
Good afternoon. I appreciate the opportunity to present to you. I have no disclosures, past or present. So, aortoiliac occlusive disease has several options, obviously open being the gold standard, but there are lots of endovascular options. Kissing stents, CERAB, which are both shown on the right, AFX, and then an IBE. The issue is majority of kissing stents, CERAB, IBE alter the aortic bifurcation, and what we know is there's a high rate of concomitant PAD, and that makes subsequent endovascular procedures difficult for these patients. We know from Maldonado et al. That the Endologix AFX endograft has been shown to be a good option in aortoiliac occlusive disease with a primary patency around 90%, primary assisted patency around 98%, and secondary patency around 100%, with a very good increase in results in decrease in Rutherford score and an improvement in their symptoms, as well as a freedom from secondary reintervention. But they did not look into subsequent lower extremity interventions in their subsequent analysis. Our group, really for a goal to maintain the aortic bifurcation and make easier subsequent endovascular interventions easier, decided to use AFX in a manner and elected to look at this in a retrospective manner. And again, the goal was to make these subsequent reinterventions much, much easier. So what we did was a retrospective review, and really we ultimately used this in aortoiliac occlusive disease with a primary focus on distal aortic disease plus significant common iliac disease, bilateral common iliac occlusions, really any situation where you needed to raise the aortic bifurcation and thus make subsequent endovascular interventions more difficult, and really any patients that were non-surgical candidates. These are the folks who generally do the best from a aortoiliac task classification. Just to be very clear, we did not use this in any patients with aneurysmal disease and really didn't use it when there was no need to raise the aortic bifurcation. As many know, the AFX is a unibody design, able to sit down on the bifurcation. It's a 17 French main body, which is not made for aortoiliac occlusive disease, but does work in this circumstance and has a separate and external PTFE compared to the cobalt chromium stent. Some of the nuances are that because of the 17 French diameter, predilation is very common. You do have to pull it down onto the bifurcation to maintain that anatomy. It's very important to avoid getting behind the struts, and really importantly, the iliac limbs are not made for aortoiliac occlusive disease, and we'll talk about this a little bit. So what we looked at over 10 years was 115 patients. The mean age, sex, ethnicity was standard for these types of patients. Again, their comorbidities, standard. Their use of aspirin, Plavix, statins were similar. And then really from a severity standpoint, about 2/3 of these patients were significant lifestyle-limiting claudicants. About 1/3 were CLI patients, with mostly being TAS C or D patients, with a high rate of concomitant infrainguinal PAD. Prior to the index procedure, about 60% of patients had known infrainguinal PAD, and about 50% of those were TAS C or D lesions in the femoropopliteal segment. Prior infrainguinal procedures were about 5 patients that had open and 8 that had endo, and you can see those listed below. Everything from lysis to SFA intervention, stents, remote endarterectomies, popliteal embolectomies, everything. At the time of the procedure, there were planned lower extremity interventions as part of the procedure, and the highest number being common femoral endarterectomy, something that's very important in these cases. But there were a few toe amputations, SFA interventions around the same time. For our cohort, we noticed that obviously all B, C, and D, with about 83% of those being TAS C or D lesions. And really, these are the patients that generally fell into inclusion criteria for what we were using it for. From an outcome standpoint, there were 115 patients that were initially trialed with Endologix AFX, but about 4 patients were not able to have it passed. 2 ended up getting a kissing iliac stent, 1 a CERAB, and 1 actually got a conversion to an open aorta bifemoral bypass. There were a few complications: cardiac troponin leak, MI very low, prolonged intubation, pneumonia, a few renal complications. Again, something like infarct, where again, if you got close with a cuff towards the renals, there was 1 patient that had a renal infarct and no neurologic complications. 1 patient had a iliac rupture and did have a subsequent stent. 2 patients with hemodynamic instability. 2 patients ultimately had an iliac rupture requiring stent, and 1 had a dissection that had to be fixed before the 30-day mark. Thromboembolism was in 1 patient in the aorta requiring a cuff, 1 in the groin, and 1 in the popliteal, both requiring embolectomies. And then in the groin, 2 patients requiring common femoral cut down and embolectomy for groin thrombosis, a few hematomas, infection. The mean length of stay was 1.6 days. A 30-day mortality, including every patient we tried to enroll, was around 1.7%, and a follow-up was about 26 months. The 2 mortalities were the open conversion and subsequent multisystem organ failure, and another patient that was a very sick patient with CLI who ultimately ended up getting a PCI and got a left main dissection. The family elected to withdraw prior to cardiac intervention. From a procedural standpoint, we had a 97% success. We talked about this. The adjuncts are listed on the right. Multiple proximal cuffs, common iliac interventions, external iliac interventions, and a lot of common femoral endarterectomies. About 72% had planned percutaneous access, with some ended up getting an unplanned cut down in about 5% of patients. The clinical improvement was that at 1 year, the Rutherford class improved from about 3.5 to 0.9. That was significant, and about 68% of patients had an improvement of greater than or equal to 3 Rutherford classification at 1 month. As you can see listed below, this is the outcomes out to 9 years and include both ABIs as well as Rutherford classification. Secondary procedures. At the time after the index procedure, about 42 patients, 37% required about 66 additional secondary procedures. About 17 of those were for aorta-iliac disease, and the remainder were for infrainguinal. Something to pay attention to was early on, and something we learned, is that this device does not work very well against very, very significant aorta-iliac disease, and it's not meant to be for this. And so we ended up, after 2016, that's shown here, relining a lot of these limbs with Omnilink stents and uncovered stents to help that. But obviously, as you can see, there was a significant number of infrainguinal cases after this point, which was greatly aided by the fact that we maintained the aortic bifurcation. Of note, there were 2 patients that ended up getting left iliac venous compression and stenting. The patency rates are listed as 86% at 72 months, primary assisted patency at 95% at 108 months, and then secondary patency of 99% at 108 months. And the survival was about 62% at 88 months. So in summary, there really is no perfect device, and I'm not trying to tell you that the AFX is a perfect device for this. But given the high rate of concomitant infrarenal PAD, maintaining that aortic morphology is very prudent and very important for these patients. This is a good, safe, effective, and durable treatment for these patients, but there are some constraints, and I think a newer device would need to have a lower profile, be hydrophilic, have better radial force in the iliac components, and really have a fused structure. Thank you.
Any questions? Then I have a question. You have a very low rate of iliac rupture, which is great. Do you have a specific sequence, any tips and tricks to fit your 17 French device seamlessly?
Early on in the series, it was, Cook dilators, serial dilation with balloon angioplasty. We've started using a lot of shockwave and using a lot of intravascular lithotripsy. So what we did was initially, we weren't relining a lot of these iliac limbs, and then we had reinterventions. So then we started stenting a lot of them, and what we've done in the recent times is actually a much more IVL in anticipation and have found that we haven't needed to actually stent a lot of those. And so I think that's been a big help. But generally, any of the things that we need to do, we had a high rate of females in this cohort. And so I think, even more prudent, we know from the TVAR data that obviously iliacs are smaller. We have to be very careful. Lots of serial dilation, balloon angioplasty, dilators, and then really IVL has been a big, big help.
Dr. Yassa?
Hi, Ines Yassa from Grand Rapids, Michigan. So I guess I have a quick question, two questions. If the device, if you're requiring Shockwave to get the device in, what additional advantage do you think the device really provided given its sort of weak structural stent component?
So in general, the goal was to maintain the aortic bifurcation, and any real common iliac stenting, a lot of these patients had distal aortic disease, so you're having to raise the bifurcation. So the point was, get the device in, reline if you need to. Now, these days, a lot of IVL, you maintain that bifurcation for the high number of subsequent infrarenal PAD patients.
And then one other quick question. In my personal experience, I have a hard time, or have had a hard time, getting insurance to pay for use of this device in the absence of an aortic aneurysm. So I don't know if you looked into rates of insurance approval and payment for it?
Yeah, we have done enough of them that generally I think our coders know what to say and know what to do, but, we're not getting aneurysm codes or CPT for this. This is aortic stenosis and then subsequent bilateral common iliac stenosis that we're getting, and we really haven't had trouble. Sometimes peer-to-peer, that's common for everything these days, but, we have not been denied any on those grounds once we explain it to people.
Have you looked at any comparisons with procedures that would raise the bifurcation, like the CRABs that you do, or the higher kissing iliac stents, to see whether or not the complication rate or anything like that and patency would be similar?
We talked about this and we looked at this, but we generally have gone so far away from that anytime we need to raise the bifurcation that we have sort of it wouldn't be a great comparison because we're either picking something that's so terrible that we decided not to use AFX to do that. So, I think it would be interesting to look into that, but I don't know that our site would be the best for it. But I think, again, it's a valid reason, an 8 French or 7 French system is better. And a lot of the time with very, very tight access, what we didn't show was, maybe it would be helpful to show, hey, what were the total number of patients in this scenario and how many did you exclude from AFX because of that and how many did you use?
Okay, thank you very much, Dr. Knowles.
Thank you.
All right, our next paper up is aortobifemoral bypass versus covered endovascular reconstruction of the aortic bifurcation, a propensity score match study by Dr. Sam'an and colleagues.
Hello, everyone. I would like to thank the Society for the opportunity to present our work here today. We have no disclosures. The treatment for aortoiliac occlusive disease depends on the extent of the lesion. Specifically for task 2 type C and D lesions, options include open repair with aortobifemoral bypass or endovascular repair with a covered endovascular reconstruction of the aortic bifurcation. We sought to compare the outcomes of patients undergoing CRAB compared to those undergoing open repair with aortobifemoral bypass. This was a retrospective study using the VQI, suprainguinal, and PVI datasets to identify patients with aortoiliac occlusive disease, those undergoing aortobifemoral bypass and those undergoing CRAB. We excluded patients at the extremes of age and those presenting with acute limb ischemia or presenting for aneurysmal disease. We also excluded those undergoing emergent cases. Our primary outcomes included 1-year primary patency rates and 1-year male-free survival. Secondary outcomes included postoperative pulmonary and renal complications, as well as major adverse cardiovascular events and 30-day mortality. To account for confounding variables, we performed a 5-to-1 nearest neighbor propensity score match, after which appropriate statistical tests were utilized to compare our outcomes. Of the patients included in our study, 6.7% underwent CRAB, while the rest underwent an aortobifemoral bypass. Patients undergoing CRAB were generally older and more often had diabetes and end-stage renal disease. However, patients who underwent CRAB presented less often with chronic limb-threatening ischemia. After the match, 81.5% of patients from the CRAB group were matched with 23.5% of patients from the aortobiofemoral bypass group. In terms of postoperative outcomes in the matched cohort, patients undergoing CRAB generally had a significantly lower rate of pulmonary and renal complications as well as major adverse cardiovascular events. However, there was no difference in 30-day mortality between the two groups. One-year primary patency rates also in the matched cohort did not show any difference in, between the two groups. However, patients undergoing CRAB did have a significantly lower rate of male-free survival at 1 year. The same was seen on Cox regression analysis with a significantly higher risk of male or death for patients undergoing CRAB. However, there was no difference in the primary patency. In conclusion, patients undergoing CRAB have similar primary patency rates as those undergoing aortobiofemoral bypass. However, they do have higher rates of major adverse limb events. Yet, covered endovascular reconstruction offers significantly lower rates of postoperative morbidity. As such, it may be an option for patients who are at higher risk for postoperative complications. Thank you.
Paper is open for discussion while we're waiting for people to come up. So patency rates are similar between the two, but there's an increased rate of male on the CRAB. And why do you suspect that would be the case?
That might be related to what was presented earlier. So higher rates of reintervention for PAD in these patients, especially if they're undergoing endovascular treatment.
So in your practice, if the patient has an opportunity for open aortobiofemoral bypass versus CRAB, which would you suggest?
It depends on the patient. So if they are at risk for postoperative major complications, perhaps a CRAB would be an appropriate choice. So it is patient dependent. And also we don't have any randomized clinical trials to make appropriate informed decision.
I know that most of the aortobiofemoral bypass data usually looks at longer term outcomes, like 5 years and so forth. I think we all know that VQI probably isn't usually the best data set to look at that, but did you take a look just to see whether or not you had enough non-missingness in those to look at a longer time horizon? Because that really might be interesting.
Yeah, so the maximum follow-up for these patients was around 18 months, so just over a year. We did have a few that extended more, but they were not enough to be able to do the analysis on them.
Thank you very much.
Thank you.
We'll move along to the next paper now. This is going to be dual antiplatelet therapy is selectively associated with decreased major adverse limb events in patients with low Wi-Fi scores, presented by Dr. Ping and colleagues from the Mass General Hospital in Boston.
All right, we'll go for it. Thank you for the opportunity to present. My name is Max Huang. I'm one of the integrated vascular surgery residents at Mass General, and I'll be presenting our research today. We don't have any disclosures to report. So the lack of level 1 evidence in post-bypass discharge anticoagulation and antithrombotic therapy has resulted in significant heterogeneity for post-bypass discharge and anticoagulation and antiplatelet therapy. This paper from the Annals of Vascular Surgery a couple months ago does confirm this. Of note, the COMPASS trial did show a benefit to adding low-dose rivaroxaban twice daily to daily aspirin, but other than that, there is a paucity of level 1 evidence. At the same time, the Wi-Fi score, so the wound ischemia and foot infection score, is a validated score to help in the management of patients with CLTI, chronic limb-threatening ischemia. However, the lack of widespread incorporation into clinical practice has yet to happen. We felt that given that Wi-Fi scores do help to predict amputation risk, we felt that using Wi-Fi scores to help
managed post-discharge anticoagulation and antiplatelet therapy would be a potential line of treatment. So as such, we hypothesized that patients with lower wound and lower foot infection scores would have more benefit to increasing antithrombotic therapy, given that those patients were at lower risk of, given the patients with the higher wound and foot infection scores were already at higher risk of amputation anyway. So we performed a retrospective cohort study. We looked at all infrainguinal bypasses from 2018 to 2021 in 3 hospitals within our hospital system, and we then classified the patients into 2 groups, a single antiplatelet therapy group, and then the second group was a dual antiplatelet therapy group and an anticoagulation group. We then excluded a bunch of the patients based on their Wi-Fi scores, so namely a wound score above 1, an ischemia score below 2, and a foot infection score above 2. And these are the outcomes we looked at. The primary outcome was 30-day male-free survival, and we looked at a host of secondary outcomes as well. So 30-day reinvention rates, 30-day graft occlusion rates, 30-day major amputation rates, and 30-day major bleeding after discharge. So all in, there are around 426 bypasses that initially met our inclusion criteria. 2 were excluded because of a lack of documentation to extrapolate Wi-Fi scoring, and then the other 16 were excluded because they were not discharged on any antiplatelet or anticoagulation therapy. Of the remaining bypasses, another 176 were excluded because of their preoperative Wi-Fi scorings. So this is the distribution of Wi-Fi scores based on the patients, the bypasses that were ultimately included. As you can see, there's a preponderance of patients with low wound scores, so around 77%, high ischemia scores, around 78% with an ischemia score of 3, and low foot infection scores, with around 91% of them having a score of 0. So this is our table 1. There are no significant differences between the 2 groups that we analyzed, apart from prosthetic conduits. There are a high rate of prosthetic conduits in the dual antiplatelet therapy and anticoagulation group, namely around 46% versus 32%. In terms of univariate analysis, we did see a higher rate of 30-day mortality, so 7 versus 1% in the single antiplatelet therapy group, a higher rate of 30-day amputation of 5% versus 1%, and a higher 30-day composite outcome of male and mortality of 13% versus 3%. And this is a logistic regression showing that the only significant variable that we analyzed was dual antiplatelet therapy or anticoagulation therapy as opposed to single antiplatelet therapy, with an odds ratio of 0.2. This is a Kaplan-Meier curve that corroborates that earlier information, showing that the differences were sustained throughout the 30 days postoperatively. So our conclusion was that selectively in patients with low wound, low foot infection, and high ischemia scores, dual antiplatelet therapy and anticoagulation is associated with lower major adverse limb events and lower mortality. And we could consider increasing antithrombotic therapy in such patients. Thank you. I'd be happy to take any questions.
I have a question to start. Based on your result, do you believe that perhaps there's an inherent selection bias just from the fact that the surgeons who placed their patients on dual antiplatelet therapy after bypass had some form of inkling that that patient was higher risk?
Absolutely. I 100% agree with that. That there definitely is, with regards to our methodology, given that it's just retrospective, that is a major limitation of our study, that there is a selection bias present.
Dr. Schoenhorn?
I have 2 questions. First, a very nice presentation. Anticoagulates and antiplatelets are quite different, so did you have enough numbers to look and see if it mattered, whether it was the anticoagulation versus the dual antiplatelets?
Yeah, I can respond to that question. Based on the years we analyzed, we wanted to have a truncated sort of period of analysis just to make, due to like different surgeons and different time periods of different practice patterns, we chose to analyze those specific 3 years. And because we limited our analysis to those 3 years, we didn't have enough numbers to sort of split it into such granularity. But yes, that is another limitation of our study, that admittedly those two categories are significantly different.
And then the other question is the single versus dual antiplatelets. Christy Marcaccio looked at that with carotid stenting and found that it's not so much single versus dual. It was a P2Y12 inhibitor alone as a single antiplatelet was as effective as dual. And so does it matter which single antiplatelet you're using?
So the majority, basically all but 2 of the single antiplatelet therapy patients were on aspirin as opposed to Plavix. So given that there will only be 2 patients in that Plavix group, I don't think we'd be able to answer that question specifically. Thank you.
Dr. Harris?
Linda Harris, just again a question about the anticoagulation. Do you have what type of anticoagulation? Is this rivaroxaban, which we already know has some protective effects, or is this warfarin and everything else under the sun? Thanks.
Again, I'll admit that is a limitation of our study. We did not go into granularity with regards to specific types of anticoagulation. I will say most of our surgeons have not yet adapted the low-dose rivaroxaban, like the twice-daily rivaroxaban dosing. So most of these were full-dose therapeutic anticoagulation. And I don't have the specific numbers on hand right now, but a good number of them were on Coumadin.
Just one question about your selection bias, because I think some surgeons would be more likely to use higher degrees of antiplatelet or anticoagulations depending on the quality of the vein or the outflow. The one way that you may be able to get around that would be propensity matching. Did you do any propensity matching or look at that? Because that might be able to help balance those 2 extremes.
No, we haven't yet, but that is something that we're considering. It would require sort of a more in-depth dive into the op notes to sort of tease out, because most of our op notes are pretty detailed, so we would theoretically be able to sort of see if there's some description of the questioning of whether this bypass would last, and the quality of the conduit based on the description. That is something we will look into.
When you were looking at the differences in male, did you see what was driving the overall increase in male? Was it major reintervention, survival, or amputation? What kind of was there not one thing that was really driving this difference between the 2 groups?
So it was, thank you for the question. It was both mortality and, I think it was on my results slide, but it wasn't reintervention and it wasn't reintervention after graft occlusion. So it was mainly from a mortality standpoint.
So something about the patients just in general?
I would suspect so.
Potentially, yeah.
We're going to keep moving on here, if that's okay. I appreciate the discussion. Thank you very much.
Thank you.
Our next talk will be risk of wound complications following lower extremity revascularization, presented by Dr. Zhu from Boston University.
Hello, my name is Shuka. I'm a 4th-year medical student from Boston University School of Medicine. Thanks very much for the invitation. It's our honor to be presenting today on the risks of wound complication following lower extremity revascularization. We have no disclosure to report. Wound complications, including dehiscence, superficial and deep wound complication infections, are common after open infrainguinal revascularizations for peripheral artery disease, and they're associated with increased rate of major amputation and mortality. They prolong the length of hospitalization and increase total hospital cost. We aim to create a risk prediction model leveraging easily accessible preoperative variables to predict wound complications after procedure, and we believe such a model would highlight potential modifiable risks and help inform discussion prior to surgery. For that, we queried the VA Quality Improvement Program database from 2005 to 2021 and identified over 22,000 patients who underwent open lower extremity revascularization. Our primary endpoint was 30-day wound complication from the operation. We created a derivation and validation set by 2-to-1 split and used generalized linear model with all 65 preoperative clinical variables. We then selected statistically significant variables for the final model. For the ease of use, we derived integer scores based on the beta coefficients and grouped patients into 4 risk categories. No differences in demographics, comorbidities, indications for procedure were present between the two sets. Most patients were white and male. Most had hypertension, are current smokers. Standard-alone endarterectomy was the most common procedure present. Of the 65 variables, 8 were significantly correlated with wound complication, with BMI greater than 35 carrying most risk. Other factors included race, endarterectomy with bypass, a relatively younger age, diabetes, leukocytosis, and a longer operating time. The 4 risk groups reflected the increasing likelihood of wound complication, ranging from 5% in the low-risk group to over 20% in the very high-risk group. Obesity and diabetes have previously been found to correlate with wound complications after revascularization. However, we did not find vein graft to be associated with more complications, whereas longer surgery as well as more involved surgery were. It was interesting to note that younger age correlated with more complications, which may be the result of having higher mobility led to exposure to infectious sources, as well as not sufficient time for wound healing. Our study was limited by the cohort being specific to the VA population, limiting the generalization of the results to other patient populations. We're currently examining our model in another large independent data set. Also, one of our variables was operating time, but it is not always predictable prior to the surgery. To conclude, we developed a risk prediction model using 8 variables and were able to derive risk scores to estimate the likelihood of having wound complication after open lower extremity revascularization. And we hope to use these scores to aid with preoperative discussions. Thank you very much for your attention, and I appreciate the invitation again and the great opportunity to work with my wonderful mentors. Happy to take any questions.
Paper is open for discussion. Do you have any questions? Dr. Islami.
I have no idea why I'm sitting there, but can you comment why did you use GLM instead of just regular regression? What was in your, in your data that made you do GLM instead of that?
Initially, I tried out both, but I figured with my Y being just 0 and 1, yes and no for complications, the generalized linear model, mathematically speaking, is essentially identical to a logistic regression in this sense.
In the VASQUIP, I think when you're dealing with a veteran population, I think most of us will know that it's a very specific population made of mostly males, and I think that was reflected probably in your demographics too. Have you guys have any plans to apply this to a non-veteran population? How do you think that might affect the suitability of a prediction model if it's primarily based on men?
Absolutely. So our other validation set that we're currently working on is essentially VMC Boston Medical Center, and it's not a male predominant population. So we hope to see great results from it.
Thank you.
Thanks.
All right, the last paper here for this session, impact of routine surveillance duplex ultrasound and subsequent reintervention after SFA stenting on amputation-free survival. Oh, I thought it was Mike Shee.
Thank you.
Yeah.
Thank you for the opportunity to present our work looking at the impact of routine surveillance duplex ultrasound and subsequent reintervention after SFA stenting. No disclosures. So SFA stenting is ubiquitous in the treatment of PAD, but it's far from perfect. And the Achilles heel really is the rate of restenosis, which is anywhere from 20 to 40% in the literature, despite recent advances in technology. So without a way to prevent in-stent restenosis, early detection with surveillance has become more important. Now, duplex ultrasound is an easy, inexpensive, and widely accessible modality that seems well suited for that purpose. However, there's mixed reports on the effectiveness of routine surveillance duplex after intervention. Therefore, there's no clear guidelines for practitioners like ourselves. So the aim of this study was to evaluate the benefit of routine surveillance duplex ultrasound after SFA stent placement. So we performed a single institution retrospective review of patients that underwent SFA stenting who also had postoperative surveillance duplex imaging over a 15-year period starting from 2005. Vascular lab reports were queried for SFA stents, followed by an extensive chart review. Our vascular lab uses a peak systolic velocity ratio of 2 to 1 to denote a 50% stenosis. We included all types of stents, including bare metal, drug-eluting, and covered stents in the study. Patients with concomitant inflow and outflow procedures were also included. However, we did exclude any stent placed for treatment of acute limb ischemia. We took all of our patients and split them into 5 separate groups based on 3 factors, one being the presence or absence of in-stent restenosis, 2, the presence or absence of symptoms at the time of diagnosis of in-stent restenosis, and 3, if they underwent reintervention for that in-stent restenosis. So for example, the first line would be an asymptomatic patient with in-stent restenosis who underwent reintervention. Our endpoints were freedom from major amputation and also patency. For patency, we used a combination of primary assisted, and secondary patency so that we could compare groups that had reintervention to those that did not. Also for patency, we defined this as duplex evidence of flow regardless of the degree of stenosis. So a snapshot of our cohort, we had 257 patients. Median follow-up was out to 4.6 years. Mean age was 64 years old, 57% males, 68% diabetics, and 39% current smokers. The indication for the index procedure was claudication in 28% and was tissue loss in 56%. We did identify in-stent restenosis in 61% of our patients. About 50% of those were asymptomatic. So our patient demographics and preoperative variables were well matched across the board, including comorbidities, indication for procedure, baseline ABIs, as well as preoperative aspirin, statin, and anticoagulant use. Intraoperative variables as well as postoperative variables were likewise well matched across all groups. I would like to mention that approximately 85% of our patients fell into task A or B, and our use of bare metal stents comprised of approximately 80% of the cohort, whereas drug-eluting stents made up about 10%, and covered stents made up about 10% as well. Now, looking at our outcomes, first we look at amputation rates. In the first row, the amputation rates were significantly higher in patients who did not receive reintervention for their in-stent restenosis. This was true for both symptomatic patients and asymptomatic patients. Next, we looked at patency, and we saw a similar trend where reintervention for in-stent restenosis resulted in higher patency rates for both symptomatic and asymptomatic patients. One final note from this graph that our 5-year mortality rate was approximately 40% across the board. Looking at the Kaplan-Meier curves for freedom from amputation, we see what we suspected from our previous graph, that patients who had reintervention performed better. This is easier to see if we break this up by symptom status. So for symptomatic patients, we're comparing the red and the yellow lines. The red line being those that received reintervention, and they did perform significantly better than those who did not receive reintervention. For asymptomatic patients, same thing. We're comparing the blue line with the orange line, and those with reintervention had better freedom from amputation. Looking at the probability of patency, we see similar trends. Again, improved patency with reintervention, And this is true for both symptomatic and asymptomatic patients. And on multivariate analysis, we were able to identify a few factors which were predictors of amputation and loss of patency. These included no reintervention on in-stent restenosis, active smoking, diagnosis of diabetes, and when the procedure was done for chronic limb-threatening ischemia. Conversely, the factors that were protective of amputation and loss of patency included patients that did receive reintervention for in-stent restenosis, when the procedures were done for claudication, and when they were on dual antiplatelet post-procedure. So in conclusion, our study suggests that duplex ultrasound surveillance after femoral stent placement can improve the long-term patency and reduce amputation rates. We feel that those with reasonable risk profiles should be strongly considered for endovascular reintervention on in-stent restenosis, even if they're asymptomatic. Future studies should focus on a prospective, randomized design to support these current findings. Thank you very much.
Dr. Wu.
Hi. Thank you for that great presentation. I think it's really challenging to do a study with 5 groups. So I'm wondering, can you explain a little bit more about how you modeled the outcome in your multivariate analysis? You said amputation and loss of patency. Like, did you model that as an and/or
They were or.
outcome?
They actually ended up.
Or was it 2 separate models?
2 separate models, and I kind of grouped them together because the outcome was actually the same for both amputation and loss of patency. It got a little bit complicated listing all the numbers, so I kind of simplified it very much so on this slide.
And how did you model no reintervention on ISR? Because some people don't have ISR, right? So, like, how did you model that variable?
I'd have to go back and check with our statistician on that one and get back to you. I'm not 100% sure.
I have a question regarding the patients who had the worst outcomes, which were the in-state stenosis with symptoms that did not undergo reintervention. Did you look into more granular data on that as to why these patients did not undergo reintervention? Were they just sicker at baseline, or?
Yeah, admittedly, that's one of the probably the biggest limitation of this study, in that there's a chance that those patients, like you said, were sicker at baseline, had worse disease at baseline, and were destined to do worse. But we were unable to identify that with our methods.
So maybe that would be something to look into, where if the overall status of the patient is deteriorating, perhaps duplex surveillance is no longer indicated in that subset of patients.
I think Melissa Kirkwood from UT Southwestern with Dr. Shi. Excellent job, Mike. I think this paper really highlights the importance of following patients that are asymptomatic. So you're exactly right. In our group, it's largely kind of, do you pass the eyeball test when we see you and you have the in-stent restenosis? And, you know, if I have a high-risk patient that is asymptomatic and they have, you know, just a lot of comorbidities, you know, I'm less likely to intervene, and I'm definitely more likely to intervene on the symptomatic healthy patient. And so that's why we did this study, because I wanted, we as a group wanted an answer as to what's the right thing to do when you see a sick patient or a healthy patient with an asymptomatic stenosis. And so you're exactly right. Those more critically ill patients, basically, it was up to the physician discretion as to whether they should do it or not. And I think that highlights the importance of the data into hopefully paving the way for future studies to look at some potential guidelines that could be set up for us. Thank you.
I think that that's a very interesting study that you guys have come up with. Nick and I were up here chatting, and it turns out that our institution follows everybody that gets an SFA intervention with a duplex ultrasound forever and ever, and he doesn't. So can we take a quick straw poll here? Whose institution will follow people relatively closely with duplex ultrasound?
For SFA stent.
For an SFA stent.
Interesting.
Yeah.
Very interesting.
All right. So
Just one question,
time for one
Ben
question.
Pierce, Birmingham, Alabama. Can you go to your conclusion for a second? Maybe I misheard you, but you said, I feel like you said somewhere in there that patients should undergo endovascular reintervention, but I didn't see any patients that underwent a bypass because their SFA stent failed. Were there those patients in the group? I missed that part.
We did. There are 20 patients out of the 257 that ultimately underwent bypass. But
Because I didn't see you compare those people's out, because it's hard to say that they should all get an endovascular intervention, and maybe that some of these people need to have surgery, right? You've done one thing, it failed. Doing the same thing again, maybe not the right thing to do with somebody with tissue loss.
yeah, absolutely.
Maybe dive into that more. That would be my question to you.
Yeah. So of those 20, the majority did undergo a repeat endovascular intervention first before moving on to bypass. But there was a handful that did go straight to bypass.
It's too small, yeah. Okay, thank you.
Thank you very much.
Thank you.
All right. Well, we would like to thank all the presenting authors today for doing an excellent job and sharing their work with us.